Hi everyone, my name is Andrea Pavon and today I will be presenting on our case presentation number 2. For patient Sal Sanders, he's age 61 years old. He's a male. His actual body weight is 79.4 kilograms and his height is 71 inches. His current medication allergies include Bactrim. He's allergic and it causes a severe rash, and he's also allergic to Lipitor, which caused rhabdomyolysis around 6 months ago. His date of admission is 4/19/2026, and his current chief complaint is that his wound isn't healing, and his history of present illness is that he's a 61-year-old male who presented to the ED with LLE feet ulcerations, necrotic in a necrotic nature. He was referred from a wound clinic for a chronic wound that is unresponsive to therapy. Under his current admission, he was referred for podiatrist consult that was requested. His past medical history includes type 2 diabetes mellitus with peripheral neuropathy, hypertension, hyperlipidemia, peripheral vascular disease, and CKD. His past surgical history, he does have a left surgical prosthetic hip that was placed 2 years ago, and he denies any social history regarding tobacco, alcohol, or recreational drugs. For his family history, his mother is deceased, but he is married. For his home medications, he's taking Humalog 34 units sub-Q 3 times a day, Jardiance 10 milligrams by mouth once daily, gabapentin 300 milligrams by mouth twice daily, clopidogrel 75 milligrams by mouth once daily, aspirin 81 milligrams by mouth once daily, and lisinopril 20 milligrams by mouth once daily. For his review of systems, they were all negative except constitutional. He had a fever and slight chills, and his skin, he has the left foot swollen with multiple ulcers. For his physical exam, his general appearance, he was a male in mild distress, and his extremities, again, with his left foot, necrotic ulcerations. For his vitals, they were all within normal limits except his temperatures, ranging from 419, 420, and 421. It ranged between 101.1 to 101.4. So it's been consistently a fever all throughout 3 days, but the rest of his vitals were within normal limits. His inpatient antimicrobials that were started were piperacillin tazobactam 4.5 grams IV every 8 hours, and it was started on 4/19. He also was started on vancomycin 1 gram IV every 24 hours, also started on 4/19, and both of these medications were started for his ulcer and wound. For his labs, the only pertinent labs to today, I will go over them when I'm presenting the primary problem. And then he also got some x-rays, but they were of the left foot, more for his diabetic foot infection. For microbiology, he did get cultures from his right and left arm. They were both obtained on 4/20, and the susceptibility was presented on 4/21. It presented gram-positive cocci clusters, and his final culture was Staphylococcus aureus. Susceptibility presented to daptomycin, linezolid, Bactrim, doxycycline, and vancomycin, and it was resistant to oxacillin, ampicillin, sulbactam, and erythromycin. Now for the patient's primary problem. So the patient's primary problem is complicated bacteremia, as evidenced by his review of systems with the fever and slight chills. I would say it's complicated just because of his past surgical history with the implanted prosthetic hip that was placed 2 years ago. And also this complicated bacteremia can also be secondary to his current diabetic foot osteomyelitis infection. It's also evident by his temperatures, like I said before, 4/19, 4/20, and 4/21, ranging between 101.1 to 101.4. Like I said, his cultures were both positive gram-stain aerobic and anaerobic bottles, gram-positive cocci clusters, final culture of Staph aureus. And his white blood cells have been trending high all 3 days as well, ranging between 16,000 to 18,000. And then he also presented with a C-reactive protein high of 7.2. So therapeutic goals would be to eradicate the Staph aureus with optimal therapy while minimizing therapeutic failure and potential for resistance, identifying and managing the focal primary source of infection as well as any secondary sources of infection, relieving the signs and symptoms associated with the infection of the bacteremia and the primary sources of infection, decreasing the morbidity and mortality associated with the bacteremia and the primary source of infection, and provide cost-effective antimicrobial therapy determined by the likely of the identified pathogen, which is the Staph aureus. And so non-pharmacologic recommendations I would give is for source control. I know the podiatrist had referred and recommended to do an amputation, and so that would be considered source control. So after that, we would try to get the secondary infection, which is the bacteremia, controlled. And so for pharmacological intervention recommendation would be to start daptomycin, 700 milligrams, 8 milligrams per kilogram. And I would recommend giving 700 milligrams IV every 48 hours due to his creatinine clearance of 30. I would recommend it for it to be 4 to 6 weeks from the first negative blood culture and when the source control was done due to it being a complicated infection. For efficacy, I would monitor additional blood cultures 2 to 4 days after initial positive cultures and as needed thereafter. Monitor for signs and symptoms of fever resolution, so less than 100.4. Monitor for signs and symptoms of infection not spreading. Monitor for improvement in white blood cell counts, and then monitoring for C-reactive protein and monitoring for negative blood cultures. And then finally, for safety for daptomycin, we would monitor for any adverse effects related to C. diff infection, eosinophilic pneumonia, hypersensitivity reactions, myopathy or rhabdomyolysis, and peripheral neuropathy. Thank you.